think it's really important because you could go talk to orthodontists and they will all have different schools of thought. Like I could list for you 3 orthodontists that would say that you can't expand that lower jaw, but I've seen the pictures and I've seen the results. So as speech pathologists going in to talk to these orthodontists, you have to be aware of the different schools of thoughts because you don't want to offend any of these doctors when you go in to speak to them, hence you don't get business. So you want to be very open and more ask a lot of questions to find out what their school of thought is and then figure out where your role as a myofunctional therapist can fit into their treatment plans. Does that make sense?
Right,
It's a really important point for us.
Right, they're not gonna want to feel like you are gonna try to dictate treatment plans or put ideas in their patients' heads. Because a lot of orthodontists, there's a lot of competition out there, and people often get a lot of opinions. And I think for orthodontists, the main impetus is getting the best result and getting the most stable result. And I think that's where you can really. That's how I sell Jennifer to the patients, and the buy-in is incredible. I'm like, you spent all this money on braces, don't you want us to say like this? Yes, okay, here's her card, yes, let's go. And I think that's where the buy-in with the orthodontist is going to be as well.
Say on the insurance policy, so that they don't walk away and say that orthodontist didn't do a good job.
Right, because no one wants that, especially now that everyone goes online and makes reviews and
Yeah,
mommy
exactly. Or go to the mall.
Like listeners.
Right. What
So,
is that?
most orthodontists will leave the expander in place anywhere from 6 to 12 months. There are different kinds of expanders I'll show you in a minute. There's ones that are glued in, there's ones that are removable. In my experience, the ones that are glued in have a lot more power in terms of actually widening the bone as opposed to the ones that come in and out of the mouth. So here's some that you might see. I'll show you 1 second. These are the kind that we use. They're spring loaded. Basically, we compress the spring, it returns to its shape. It's called slow expansion. So it
And what's
happens
the
over a
name of
period
that
of time.
model? Just so they
It's called a combo jet, but again,
Combo
there's like
jet.
a million of them.
Yeah.
So that's just what the lab calls it. There's a slow expansion which happens like gradually over time. It's more comfortable for the patient. But a lot of orthodontists, most use this appliance called. It can be called a Hyrax appliance. It's when you have a key and you turn it, and that's called rapid expansion. And you turn like once a day or once every other day, and it tends to be more sore. I don't know, Dr. Light always used this jet appliance. That's what I've always used since I've been there. But this is what we used in residency. Dr. Cook, I think probably had experience with both.
I would only
don't
use
know.
that one if they were like 13 or 14.
Oh,
This one,
only use that one.
right?
The heavier one. I use the same one that Dr. Goodman uses for
Okay.
anybody younger.
I
Yeah,
think
for-
the other, like, I can think of 3 other orthodontists that I work with that all use Hyrax.
Most use
Rapid
Hyrax.
expansion
Yes,
and then holds in place for 6 months.
and then holds in place. However, I will say if you don't get their tongue in the right spot, expansion will relapse no matter how long you keep this in.
Unless if you refer to the speech therapist, I like to get in there literally the week that expander comes out. I like to work that next week.
Because if the tongue isn't supporting the expansion, it's just then tongue's down. It's just to some
When I
degree.
came out of school, I don't think they had the jet appliances yet. So
Yeah.
all
So
I
Jet
had
is a newer, the Mambo Jet is a newer,
I think it is, and a lot of I don't know. I'd never used it before I came to Dr. Light's office.
and that's slower expansion.
Mhm.
We talked about that
It's
over.
more. It's like because it's like a spring and it returns to its shape. It's just very gradual, but
But no matter what kind of expander they use, they'll benefit from.
yes.
So I don't think you have to try to remember which of the appliance, because
No.
I don't know them. I'm
Uh-huh,
a pediatric
yeah.
dentist. Like, I have no idea what she's talking about right now. Like, I couldn't
And you don't-
like, I mean, what I mean is, like, I couldn't tell you the name of any one of those. So you don't
Right.
need to stress about that. You just
No,
need to.
yeah.
Ask them what they
What
use.
Dr. Goodman just said is, when your expander comes out, you don't want things to deflate. I can help teach that tongue to support the work you've done.
Yeah, it almost doesn't matter. I just wanted to show you just so if you like see it in a kid's mouth, but everyone's going to use something different. And they all in a pre-pubertal child, any appliance you use, you're going to get actual bony expansion, which is hard to do once the bones in the head mature, which means that the okay, so this is the palate. There is a suture, it's called right here. There is a ligament holding these 2 shelves of bone together. When the bones in the head start to mature, we think around age 10 or whatnot, bone fills in here. And then you can't expand anymore. You can't split this suture to expand
Right, so all those kids that were thumb suckers, and they get those expanders in, and they've been mouth breathing, all of a sudden the expander comes out and it's like amazing how much more airway space they have in the nasal cavity and within the mouth to be able to teach that tongue to live up. It's like perfect timing.
Right. So here's just an example of a case from my residency where I did an expander. This girl's a little bit older, but this is a couple examples of this is how we retain expansion. I think it's pretty common, just two appliances you might see in your patients because at least the way we do it is, and I'll talk about this a little bit more later, we do the phase 1, we take out the fixed expander, and then we'll send to the myofunctional therapist, and they'll be in some sort of retainer. So this is called a Hawley retainer. They wear it at night. It's removable. I'm sure everyone has seen one. Jennifer, I'm sure, will talk a little bit about how she makes a little hole in it to help them practice their tongue exercises. There's another appliance called a Nance. It's a fixed appliance, meaning it's glued in. I will do that sometimes if they're losing a lot of teeth and there's not a lot for the retainer to hold on to, or if they have problems like with compliance.
So can I ask a question?
Yeah, go ahead.
Just for, in the sense of the timing for referring, so you have, as she showed the picture of the posterior crossbite, but the anterior open bite. So when is it that I'm going to be sending the patient to use? I'm diagnosing this now.
At
but
what
I-
age?
You want me, so they're the mixed dentition, so you said that you refer after you expand?
Well,
But
we
they have, like,
kind of changed that a little
yeah.
bit. That used to be the kind of the way I would encourage. I'd say, okay, tell them about it, put your expander in, and then as soon as the expander comes out, they need to call me so we can get to work. But I've changed that because I think now, and I really believe in an earlier intervention than I ever did before. So for maybe 5 years, I was like, wait till the expander comes out. Now, I think that there's stuff that we can do prior to that expander going in, then let the expander go in, so we can get some natural work done, get the expander in, and then as soon as the expander comes out, we go back to work and really let the tongue live in the penthouse that was built for them. But before that, you have some kind of quirky, it's still living in the basement, it's kind of tight up there, it's like a very tight apartment for it to be in. We're doing some exercises to teach a proper swallow or do what we can do, but we know that it's going to be this nice spacious place for it to live after the expander comes out. But I do like an earlier referral than I ever did before, because now I think that there are things that we can do just to educate and make the child more aware of their oral facial posture, their tongue, what's going on in their mouth. And we really like to work with the little ones when they're still in the dentistry stage, because I think we can do some intervention and have some success then too.
Then with the exercises that you are giving them before the expander goes in, when the expander is in, does that?
Like make it obsolete. So like a lot of times I would work with like a patient with a real severe tongue thrust. I'll teach them a proper swallow. I'll teach them and educate them on why the tongue should rest up on the roof of the mouth. The expander goes in and we know for like a month, 2 months, they're gonna, be doing, I call it the expander slurp, like trying to adjust to a new way to eat. And then it kind of like evens out. So maybe I'll see them a couple times once they adjust to the expander to say like, I know it feels odd up there, but look, you can still use the expander as a guiding point. I especially like it when I have to teach an R sound. We can use the back of that expander as a perfect place for We can use that expander as a place to get the tongue tip, because it still allows for that tongue tip to go up on the bump or the ridge. So I still can work with them a little bit, not for regular therapy sessions, but just to increase awareness and talk about how we're adapting to this big piece of metal in their mouth, knowing it's not going to be optimal. I can still, as it stays in, work a little bit on nasal breathing. Work a little bit on, now you're going to actually be expanding, you might be able to breathe a little better. Let's encourage as much lips closed as we can. So just some little baby steps along the way, and everybody's different. Like I just saw one of ours, I saw him like 2 or 3 times, and now I won't see him until the expander comes out, and then we really go to town.
I have a quick question.
Yeah.
Have you noticed that your patients are getting more or less compliant with or okay with the expander if they've already met with Jennifer?
Be compliant with.
Well, I just know that they all hate them.
The
And they
expanders?
complain, yes, and they complain about it. And I'm wondering if they see the speech therapist a little bit beforehand, if they're just like a little bit more okay.
Maybe a little more
have-
comfortable.
Comfortable.
I can think of like this one guy in particular, he was very anxious, parents were a little bit anxious, and then he got it and it was like, okay, like we talked about what this was gonna be, we talked about the reasons for doing it. I felt like from an educational standpoint, the kids understand it a little bit better, so maybe yes to that.
Yeah, I think that's a good point because there's more buy-in